to start by thanking Ben back in 2010 at the first MAP Psychedelic Science Conference. I'd known about Ben by reputation, but I hadn't met him. The first time I saw him, I pounced and said, if there's ever an event in the UK, please consider me. When I'm led in a guided meditation, I imagine myself sitting under a trees, in Holland Park. It's my happy place. So I want to start by expressing my gratitude to the entire Breaking Convention crew for making this event possible. So this talk is going to be a bit of a hybrid. Dr. Grobe and I have presented at Grand Rounds recently where we needed to be very formal and all science. Taking into account the multidisciplinary audience we have today, I've taken some liberties to make this talk a bit more fun, if you will. But I think there's enough science to keep the scientists engaged and informed. If we can everyone see the slides? It is important to see the slides in this presentation. Okay. So today I'm going to be updating you on a current pilot study of MDMA-assisted therapy for social anxiety in autistic adults. It's taking place at LA Biomed at Harbor UCLA Medical Center, and this is a MAPS-sponsored study. Charles Grobe is the principal investigator, and I'm the co-investigator on this study. So this slide serves as an agenda and an overview. What I'm going to be covering today is the rationale and method for this current study, as well as a bit of an update at the end. Turn on my stopwatch so I don't go long. There we go. In March, we took a somewhat unusual step of publishing a paper on the rationale and method in the journal Progress in Neuropsychopharmacology and Biological Psychiatry, in part to start informing the scientific community as well as the public in general about this study, because there were so many misconceptions being reported in the media. And we also wanted to potentially increase the impact of the findings paper to be published, I would hope, by the end of next year. So why did we find it necessary to take this step? Because of the novel nature of this study, we got some early media attention. I would have preferred to have none, but this is what happens. So take a look at the slide and just think to yourself for a moment, anything wrong with the way this study is being reported? I can only find one thing right about it. It's a social anxiety study. Not working with any ecstasy, and definitely not trying to treat autism. And I certainly don't approach our participants with a handful of rainbow-colored ecstasy tablets and say, whichever color appeals to you, take that one. So this trend continued, and it got worse and worse. But it really didn't get worse than this. These messages alarm me because these are the types of headlines that I fear will result in a parent of an autistic child dosing a 3-year-old. So I want to enlist your help in this community today in helping get accurate messages out there. Please respond in discussion forums online, write to journalists, and correct them when they're reporting inaccurately. So some key points. It's a social anxiety study. We're not treating autism or seeking a cure. Very limited MDMA. I've been attacked online. How dare I advocate prescribing daily MDMA? It's MDMA-assisted therapy. Our research is informed by the neurodiversity paradigm. Simply stated, human brains are different. And we work from that perspective as opposed to a pathologizing perspective. And the influence on our participants is notable. For this reason, I don't use person-first language. If you're accustomed to hearing autism researchers refer to a person with autism, it was pointed out to me that that somehow implies someone could be without autism. It's a genetically based neurological variant, and we use it just like an adjective, like artistic. So for this study, it is a randomized, double-blinded, placebo-controlled pilot study. We're looking primarily at safety and feasibility. Efficacy is the third priority. It's a dose-finding study because during my dissertation research, I got some feedback that a dose that's considered appropriate for typically developing populations may be overstimulating. So in our first group of 6 participants, they were given 75 milligrams in the first session, 100 in the second. We're into the second group now. Those individuals receive either 100 milligrams in the first session and 125 in the second. 4 individuals are randomized to an inactive placebo group. Only 2 sessions with MDMA over several months where participants prepare. I'll say a little bit more about how we prepare. And then afterwards, the really important work, we do 7 days of phone call post-treatment with integrative visits to help optimize any potential benefits. We follow it for 6 months, primarily looking at safety measures, and then we come back in at 6 months and gather every type of data again to compare to baseline. And we're also constantly taking blood pressure, temperature, checking everyone's vitals. Our primary outcome measure is the Leibowitz Social Anxiety Scale, clinician-administered interview style, and we have a completely blinded independent rater, Dr. Chris Struble. We don't talk to him about our impressions of our belief of assignment to a group. And as well, we're collecting lots of secondary measures, some more pertaining to safety and others looking for other potential future indications for this research. So note about empathy. Many people right out of the gate assume we're somehow trying to instill empathy in a population that's entirely lacking it. These drugs are referred to as empathogens after all. Really, nothing could be further from the truth. If you stop and think about it, empathy is a very, very broad set of constructs. It's like when people refer to drugs. Are you talking about an aspirin, or are you talking about something that could be very harmful or even fatal? Empathy is very broad, but it can help to divide that concept of empathy into 2 broad categories. Cognitive empathy, being able to understand what might be going on with someone else based on what you're observing, versus feeling for another based on their condition. There's a theory that in autism, there's an imbalance where these individuals actually are disabled or challenged when it comes to interpreting the cues that allow one to experience cognitive empathy, but they may experience more affective empathy. And if you're interested in this area, I encourage you to investigate the intense world theory of autism. This theory, it's kind of a unifying theory of autism that says these individuals are hypersensitive, hyperreactive, and that the autistic behaviors may be sort of a pushing out, that they may be experiencing very high levels of affective empathy. The IRI is one of the measures that I really like because the subscales look at these different constructs of empathy. So I'm very curious. I'm staying blinded to the results as we go. I'm very curious what our results on the IRI will look like. We're also doing blood plasma analysis. Researchers at Stanford will be looking at oxytocin, vasopressin, and cortisol to compare to samples taken from typically developing populations. A word on our participants. They all are rated as having moderate to severe social anxiety. We have another independent rater who administers the Autistic Diagnostic Observation Scale for adults. This is often overlooked in autism research. They don't use one of the gold standard measures to determine if the people participating are in fact autistic. We do. Hasn't been difficult to find a population that's MDMA naive. Everyone has 2 years of college or comparable in lieu of an exhaustive battery of IQ testing. So that tells you about the level of functioning. People are always curious about that. All of our participants are able to communicate with us by speaking quite readily. It's not a problem. So a little bit more about who is participating in this study. It's kind of the light blue margin there. Most of the individuals who have enrolled would have the old Asperger's diagnosis. Doesn't exist anymore with the publication of the new DSM. But one of the reasons we're working with this population, their autism often isn't readily available to others, and so they are held to the same standards of understanding social norms, and that can really enhance the discomfort and the social anxiety that they experience. We worked with autistic individuals. We have a member of our team who's an autistic self-advocate who's been advising us at every step through selection of the measures to how we set up the treatment room. He reviews all of our documentation that's shared publicly to make sure that we're not publishing any messages that are harmful to the autism community. And I'll say a bit more in a moment about how both quantitative survey research and qualitative research that I did for my dissertation informed our method and approach for this study. So as part of my dissertation, I did a quantitative survey with 100 individuals who identified as being on the spectrum and asked them about effects of ecstasy use. And this is an abbreviated list of some of the symptoms. What you're seeing here, I'll explain. On a 7-point Likert scale, this column represents the 0, did not experience this effect whatsoever. This column is the 7 option, where someone reported strongly experiencing an effect. And at this point, I'd like to pause to just give you a moment to take in the content on this slide and note the contrast between the two columns. If you have difficulty reading it, please see me afterwards, and I'll explain what's on the slide. How am I doing for time? Okay. Everyone have a chance to take that in? All right. Now note the comparison. Not all of the effects were positive. You know, per Terry's talk earlier, there are safety considerations and there are risks. So some negative effects were reported. And note what happens in the two columns with the percentages. Okay. So based on what began as a trickle of anecdotes that started appearing online, these anecdotes, a handful became dozens, became hundreds. We thought, all right, there's some smoke here, let's see if there's fire. So I kind of formalized the data gathering with the dissertation research and tried to start quantifying what people were reporting, autistic adults who were reporting ecstasy use. 72% reported more comfort in social settings. 12% reported this effect lasting 2 years or more. Now, not everyone in the sample of 100 had reached the point where 2 years had passed since they took MDMA, so these numbers are likely to increase as more people hit that 2-year mark, if that makes sense. 78% reported feeling at ease in my own body. 15% that effect lasted 2 or more years. Easier than usual to talk to others. The bottom percentage there, these are the percentage of the interviewees. I did 24 semi-structured interviews, and 58% of the people I interviewed spontaneously reported a reduction of social anxiety symptoms. So I applied a method for qualitative research known as thematic content analysis, poured over thousands of pages of transcript over about 11 months, looking for emergent themes, bracketing my biases, and repeating a process over and over, just looking at the meaning units in the content. And it was convenient for me that 5 main themes emerged, and I could make them all start with C. So my little mnemonic is the 5 C's. So what were the 5 C's? Okay, just a brief note. When people talk about psychedelic experiences, you frequently hear people refer to going down the rabbit hole. When I think of autistic populations taking MDMA, I think of them taking a trip down the yellow brick road. So the first theme that emerged, courage. People would talk about having the courage to flirt for the first time, to jump out on the dance floor, to initiate a conversation, to put themselves in social situations that were previously inaccessible to them. And you can guess where this is going. Communication, lots of different subcategories, sub-themes under communication. Being better able to listen to someone in conversation and focus and take in what they were saying. Being better, many people report, well, I say many, a high percentage of the people I interviewed reported a sensation that they suddenly could interpret body language. A lot of them would acknowledge that they didn't know if they were accurate or not, but they felt as if they could interpret body language, facial gestures, sarcasm. They knew when to tell a joke and just noticed a sort of facilitation of communication that they hadn't experienced before. It kind of follows logically that this would lead to a sense of connection. A lot of themes related to connections to friends, being able to initiate romantic relationships. Several times I was told there was sort of a realization like, oh, it hadn't really occurred to me that my parents do all the things they do for me because they love me. And that led to a depth of connection with family members and siblings that they hadn't experienced prior. Taking that trend sort of a cut further, there's this concept of communion, this deep empathic bonding, sharing of insights, and feeling a sense of unity, a connection to a group or a cause. One gentleman from the UK shared with me that he had his first experience on a commuter train riding home after his first Ecstasy experience, and he and a group of people seated on the train were sort of adoring a small child. And he was aware of the nonverbal communication between all the people in the group, that they were doing the same thing at the same time. And this was very pleasurable for him. So it was his first experience of communion. And I have seen this look, this exact look, in our treatment sessions. The most unanticipated and kind of remarkable finding from the dissertation was this theme of clarity. Whereas typically developing populations describe, Dr. Groballs does this is MDMA. It's heart opening. With autistic adults, they're frequently talking about mental clarity. My thoughts straightened out. I had laser focus. The thought loops in my head quieted down. Clarity seems to be extremely pleasurable when adult autistic research participants describe what MDMA is like for them. So a very important point to keep in mind, no one told me that ecstasy somehow miraculously made them no longer autistic. And as I was writing up the findings, the song lyrics, Oz never did give nothing to the Tin Man that he didn't already have, kept going through my mind. A lot of the respondents reinforced this notion that they just had more aspects of themselves available to them, or they were just themselves, but there was sort of an enhancement there. But it was already there. We didn't deliver empathy in a pill. Okay. So how do we prepare our participants? How am I doing for time? Oh, good.
10 minutes.
Good.
No, just over 10 minutes, that's it.
Perfect, perfect. Okay. So how do we prepare adults on the autism spectrum who have never had an MDMA experience? The therapy that we provide in the preparatory sessions is more skills-based. The literature base suggests that there are barriers to conventional psychodynamic therapy. It's difficult to establish that rapport. So we start with something pragmatic and skills-based. This is dialectical behavioral therapy-based, the core mindfulness module. DBT, if you're not familiar with it, is an intervention that was developed primarily for populations with a borderline personality disorder diagnosis, but it's been found to be effective. It's an evidence-based therapy. And it was a good match for our population because this core mindfulness module is foundational. DBT progresses to interpersonal relationships, emotion regulation, and distress tolerance, which are all areas that can be challenging for individuals who are autistic. So I'm always looking for graphic representations for our study participants who are visual thinkers. This diagram sort of represents the ideal that we strive for, to have a balance where our reasonable mind isn't a big bully shoving out emotions and minimizing them, when the self can kind of consult different aspects of their inner experience. Ideally, you arrive in this intersection, a little Venn diagram of the wise mind. When I ask our participants at the first preparatory session to draw their model, it often looks like this with autism. One participant, again, I'm still blinded. I don't know what was in that capsule, but the initial drawing reminded me of the Charlie Chaplin film when he's going through the gear works. There were big clunky gears that didn't quite fit together. And post-session, when we revisited this diagram and said, draw me a representation of your inner experience, drew a figure completely integrated that looked very much like a heart and lungs and a very organic, connected diagram. So it's interesting when we give people another means to describe their before and after. So this is where that clarity is apparent in our studies. When people say, for the first time, I'm more aware of the emotions coming in, and I realize that my thoughts are just thoughts, it's not the totality of who I am. Other steps we take to prepare, we do a lot of intention work. I discuss in detail everyone's communication preferences because they vary widely. The most helpful advice I got when I began this research was, remember, and this is how they used it, the term, you've met one aspie, you've met one aspie. It's an exceptionally heterogeneous group, so I always start with the individual. How do you prefer to communicate? I work very hard at communicating in very literal terms. I use a lot of analogies, but I'm careful to explain them. We do a lot of work exploring the 5 senses, helping people maintain a sense of bodily awareness. And similarly to the precedent set by Michael and Annie Mithover and the other MDMA-assisted therapy for PTSD researchers, we emphasize the wise inner healer and trust that the individual is the expert on their life experience, and we try to follow their lead. Being trained in very indirective approaches, I learned early on, I need to be directive more often than ordinarily I would, because you ask a lot of our participants, like, how was that for you? They'll draw a blank. So we need to, we are better able to support our participants sometimes with much more directive approaches in therapy, but remain indirective as much as possible when it counts. And I'm just more careful than I would be with typically developing participants to explain exactly what's going to happen at each visit and lay everything out so there are no surprises to help everyone stay comfortable. What do? We always start with the grounding relaxation, take vitals hourly. We do use the kind of Graphian model of eye shades and music to go within, but because this is a social anxiety study, it wouldn't make a lot of sense to have somebody just go into that space and then say, how was that for you? So we do interact with them. We use an assessment known as the TACIT. It's a test of nonverbal social cues. And that was sort of a way of bringing more social interaction into the room, and also to test this notion when people say, I was better able to interpret other people's emotions on MDMA. Well, were you really better, or did you just think you got better? So we tested baseline actually during the peak effects and at outcome to see if there's any improvement in interpreting nonverbal social cues like gesture, tone of voice, sarcasm, sincerity. Do a lot of bodily awareness work to help everyone feel integrated and grounded. Have everyone create a visual diary, kind of comic strip style, to kind of draw the story of what happens during the session, because it can be helpful, when you're in that ineffable state and you can't quite put words to it. Sometimes it's just a color or a texture or a shape. And then we can use that tool for the integrative appointments afterwards to revisit the session and help remember anything that was of value. And we always do the closing with the support partner. In lieu of having our participants stay overnight at the hospital, we made an adjustment, and everyone has an official study support partner consented into the study. It's not because we have concerns that the individuals we're working with are so disabled that they need a caretaker. It's to be that grounded, compassionate, attentive, good listener presence for the 24 hours after until they come in the next day for the first integrative session. The support partner is also responsible for driving. We have a very autism-friendly space, never turn on fluorescent lights, always bringing in elements of nature when possible, and just taking into account the hypersensitivity of sensory awareness in our population. So words are okay, but pictures will tell you much more about the space. This is what we inherited. This was the before. It was probably the ugliest room on campus I'd ever seen. Due to a generous donation from the Betsy Gordon Foundation at Startup, we were able to create this. And due to generous ongoing support from MAPS, we're able to bring in flowers, great music, good food, and keep the show running. Another look at the before. Probably the smartest purchase. This was our big ticket item where I kind of stretched it, but it was worth every penny. We got, it's a motorized recliner. I call it the hand of God. It's just, reclines all the way. And it also enhances that sense of agency in our participants, so they're in control. Okay. I know there's scientists here today. Quick slide on potential mechanisms of action. There's research in these various areas underway. Some of the ones we think may be applicable to our research, that increased sense of well-being, oxytocin, helping connect and bond with others. I think one of the most significant potential mechanisms is the reduction of the fear response, the amygdala. And these aha moments, maybe if things are speeding up in the prefrontal cortex, we get the scarecrow moments. So what you've all been waiting for, the progress update. We've enrolled 9 participants. 7 have been treated. A lot of times I'm asked any women. I was really hoping to get 3 to kind of get a representative sample. So far we've had 1. If you know any women in the Los Angeles area on the spectrum who might be appropriate for our study, please send. In fact, if you know anyone. 1 participant dropped after the first session, wasn't related to a safety consideration at all. It's interesting to note that our inquiries have been very steady. We've never had a really bad fallow period where no one was contacting us. Interest from across the United States, all regions of the US, and internationally as well. However, our participants need to live within about 30 miles of the study location because they need to come in for about 15 office visits over several months. Absolutely no serious adverse events. We've had some spontaneous reactions, but none that were unexpected. Things like headache or fatigue, but nothing we've needed to report as a serious adverse event. And all I can share with you today is that at the midpoint, our sponsor monitor at MAPS did a safety check, and there were no evidence was found of any harms, looking at all the data, all the safety data, all the outcome measures, and we're seeing some early trends toward positive outcomes, and I'm really looking forward to giving the talk when I can talk about findings. So here's how you can contact our research team if you want more information about the study. And thank you very much for coming today.